So good afternoon. We're going to move on to a session on paper writing and review. And we'll have two Zoom presentations, first by Dr. Washer from the US. And then I have the pleasure to introduce Richard Veller, who will bring the art of publishing a paper. And I remember Dr. Veller since many years, because I guess as I look at his personality, we started hip arthroscopy about at the same time. And even though I moved on to knee arthroscopy and knee surgery, ladies and gentlemen, if you want to listen to the best English presentation ever, then this will be by Richard Veller. So I'm always following him whenever he presents, and I have the chance to be there because the English is just so wonderful. So thank you again. And then we'll move on to Mohamed Rossi, who will present also by Zoom. So can we have the technicians get into the Zoom of Dr. Washer, please?
Thank you, Renee. Can everybody hear me fine?
It's okay. Perfect.
Okay. My name's Dan Washer. I'm from Albuquerque, New Mexico in the United States. I wish I could be there in person, as I've always wanted to visit Greece, but I will have to Zoom this time. I was asked to talk on how to organize your research plan. I'd like to thank Dr. Isophides for inviting me to participate in this Congress. These are my disclosures, and of note, I'm on the editorial board of the American Journal of Sports Medicine and the Journal of Knee Surgery, and I function as an associate editor for the online open access journal, Orthopedic Journal of Sports Medicine. A little disclaimer, the focus of this presentation is going to be on clinical research, not on basic science research, systematic reviews, or meta-analysis. And these are going to be my thoughts on how to organize a research plan, as well as some lessons from some Greek scholars. So what is research? Research is an investigation aimed at the discovery and interpretation of facts, the revision of accepted theories in the light of new facts, or practical application of such new or revised theories. And here's, as Herodotus said, nothing ventured, nothing gained. So I would encourage all of you to participate in research of your clinical patients. So what makes a good research plan? I think there's three main things that need to happen. One is asking good questions. Two is executing the research plan with good methods. And then finally, a good analysis of your data. And I think a plan is really key to a successful research project. A good plan will make research much easier. And as Plato noted, the beginning is the most important part of any work. So the first key is to ask a good question. And in my mind, it should be something that interests you. Is it a relevant topic? Is it a question that has already been answered or maybe needs some confirmation? Do you know the answer to the question? Or has the question changed? But again, I think if it is a topic that is of interest to you, the chances of completing the research project are much higher. I think it's very important to avoid bias at the beginning of starting a research project. Research is designed to answer a question, not to confirm your beliefs. And as Aesop noted, every truth has two sides, and it is well to look at both before we commit ourselves to either. So where do you find these good questions? Well, one might be looking at what sort of local expertise and experience you have. Here in New Mexico, we see a high volume of patients with knee dislocations, and we've done a lot of publishing on our experience with those patients with knee dislocations. Different opinions within your department are a great source of research questions. We had some of our faculty that would scope all of their MPFLs and others that only scoped when identifying loose bodies on preoperative imaging. So we did a study looking at whether scope was necessary when performing an MPFL reconstruction. Uncommon conditions and uncommon treatments are more likely to get published than topics that are very common. I think evaluating new procedures or implants is an important research question. And I think reading the current literature will help you identify gaps in the literature or future questions that need to be answered. I think it's important to know your local resources. It's difficult to do a study on gait analysis if you don't have a good gait lab. So look around your institution and see what sort of basic scientists or other clinicians are available to execute your research project. Look at what databases you have, whether medical records, electronically, collection of patient-reported outcome measures, or radiology files. All of these can be great sources for research projects. And I think it's important when you identify people within your institution that can help you, if they have an interest in the project, there's a much better chance of the project being undertaken, as Euripides noted. Know the levels of evidence. Certainly randomized controlled trials are great research studies, but all research, not everything needs to be a randomized controlled trial. Cohort studies, case controlled studies, case series, and even case reports can add valuable knowledge to the literature. I think it's important before you start your project to look at the requirements. So if you're going to do a randomized controlled trial, look at the consort checklist. If you're going to do a cohort case controlled or cross-sectional studies, look at the strobe checklist. And if you're going to use autologous blood-based therapies, look at the minimum investigation for biologics and orthopedics recommendations. These are all very important requirements before starting your study to know, so that you can make sure that you've got all of these checklists covered. Before you start your research project, you should have a hypothesis. That might be that procedure A will improve patient outcomes, or the procedure B is better than or equal to procedure A, or finding X will be more common in population Y. But a hypothesis is a question. It's not a bias, but it's a prediction. Understand what you're going to measure and how you're going to measure it. This could be patient-reported outcome measures. These can be general outcome measures or disease-specific. Ideally, these are validated measures in the literature. There can be objective measurements, which can be clinical examination. It can be imaging findings, or it can be complications, whether it's revision rates, infection rates, et cetera. And as Archimedes figured out how to measure gold by sitting in a bathtub, oftentimes your best ideas come outside of the clinical setting. It's important to understand how long you're going to need to measure things. So the length of the follow-up depends on the outcome being measured. If you're doing a radiologic study looking at slope in patients with ACL injuries, you really don't need any follow-up. But if you're going to look at return to sport after a procedure, you probably need at least 2 years of follow-up. And if you're looking at long-term degenerative factors related to an injury or procedure, it's really going to need to be a long-term outcome study. Before you start your study, conduct a power analysis. There's nothing worse than a good project that is underpowered to show significant differences. So the primary factors are going to be the effect size, the significance level, which is usually 0.05, the power, which is usually 0.80, and this will help you calculate your sample size. And this is a nice website that has a nice algorithm that you can plug in numbers and see what kind of sample size you'll need to answer your question. The effect size, such as a change in patient-reported outcome measures, should be higher than the MCID or the PASS. It's important to understand who's going to collect the data. You want to make sure if you're doing clinical examinations or radiologic evaluations that you've got people that have the requisite skills and training in order to accurately assess the patients. You need to avoid the risk of bias, and I think it's a bad idea to have the primary investigator or the surgeon of record evaluate their own patients. I know in my practice that my patients' Lockmans always seem to be better than other surgeons. And then if you have multiple examiners performing multiple measurements, perform intra and interclass coefficient correlations in order to see how accurate the measurements were. It's important to get institutional review board approval. This can be onerous in some institutions, but it is important for patient safety. And the requirements can vary by country and institution, but this should be stated in your methods. Now you get to the hard part, which is collecting the data. If you're doing a prospective study, you have to recruit patients into the study. And if you're doing a retrospective study, you have to find and identify patients that have had the disease process or procedure that you're studying. I think it's important to collect more data than you think you need. And this is really where I think the effort is most important in undertaking a research project. And the success is really dependent on the effort, as Sophocles noted. Once you have all your data collected, analyze your data and start with the most important data that answers your hypothesis, but also analyze the other data you've collected to see if there's any interesting findings there. And I think it's important to involve someone with statistical knowledge to help analyze the data and to conduct appropriate statistics to see if the findings you have are significant or not. Now, all you have to do is write up the manuscript. And as Pericles noted, having knowledge but lacking the power to express it clearly is no better than never having any ideas at all. And unfortunately, many good studies never get written. I think it's important to use a writer that has fluency in the language and avoid pre-existing bias when presenting your results. State the results clearly and interpret them honestly. The paper should include an abstract, which, as Pythagoras noted, it should say a little or should say a great deal in few words. This should summarize your rationale, hypothesis, method, data, and conclusions. Remember, many readers only read the abstract, so you want to make sure your important message is contained within the abstract. The introduction should tell the reader why this research is necessary and introduce any prior work in this area. The method should be clearly explained. They should state IRB approval, the inclusion and exclusion criteria, the method of data collecting, the number of patients lost to follow-up, and the data that was collected. You want to summarize the findings within the text, within the results, and primarily use figures and table to convey the details of the data. I've seen too many papers that just go on presenting their data in the text, and it makes it very difficult and boring to read. Whereas when you have figures and tables to look at, you can readily convey the important details of the data. Finally, in the discussion, you want to summarize your major findings, but don't repeat all of your results. You want to compare and contrast your findings with prior research. And most importantly, I think you want to discuss how your findings will affect future clinical practice and suggest any future directions that need to be undertaken. And then finally, your conclusion should be focused attention on the major results of your study and avoid any opinions or conclusions not made by your study. So in summary, a successful research plan asks a good question, has careful planning of data collection, undergoes thorough data analysis and statistical analysis, and then has an unbiased analysis and discussion of the results of the data collection. Answering a question usually leads to more questions, and as Socrates noted, true knowledge exists in knowing that you really know nothing. I'd like to thank you for your attention and welcome you all to come visit me sometime in New Mexico, and welcome to attend the AOSSM 50th meeting in Colorado Springs this summer in July. Thank you.
Thank you, Dr. Washer, for this excellent introduction to medical writing. It was very helpful, I think, for our young people. And also, congratulations, because you combine science with philosophy, and very, very good philosophical comments. Thank you. Do you have, is there any questions for someone, from someone? No?
Our fellow speakers allowed to ask a question?
Yeah, please.
No, it's Richard Miller here.
Yeah, in a microphone. Dr. Villar.
Ricky Villa here. Well, I think I'm actually the next speaker, but how do you handle it when a registrar, a junior, comes to you and he's been given a whole load of data? You know, why don't you look at my last 60 hip replacements, for example? Or why don't you look at how my ACLs are doing? The data is already there, but he doesn't know what to do with it. You presented a perfect plan, but what about the poor guy, the poor trainee?
Yeah, again, I think before you look at the data, you have to have a question. And again, I think that's really important. And again, you might talk to him about what hip prosthesis do you use? Are you using different prostheses? Can you compare those? You might ask him to compare his results with one of his partners who has a different technique. So again, the key is to look at a question, to find a question, and it's great to collect data ahead of time, but just having data doesn't really give any meaningful use unless you have a good question that you can answer and a hypothesis that you can answer.
Yeah. Do you have any question? Yeah.
So thank you very much, Daniel. I hope it's not too late for you out there.
It's actually early in the morning out here.
Yeah.
Good morning.
Morning, yes. So thank you again and enjoy the rest of the weekend. It was a pleasure to have you here in Thessaloniki.
And next.
Thank you very much.
Bye-bye.
So then we may ask Professor Villar to join us on the podium and speak about the art of publishing a paper. It's probably a different approach, but the means are probably the same. So thank you for having time to join us here.
It's a great pleasure, gentlemen. Ladies and gentlemen, I notice the auditorium is half empty, which sums up why sessions like this are important. It is an art. You focus on 100 ACL reconstructions, 200 hip replacements, whatever it may be. You regard those as being criteria by which you judge your skill. You presume that because you speak English, you can write it. That does not apply. As much skill and tricks of the trade are needed for writing papers as there are for reconstructing an ACL, doing a hip replacement, and other things as well. Now, why am I standing before you? You see, I enjoy writing. I blame this guy. This guy was my great-grandfather. If any of you have read a paper called The Daily Mail, he was one of the very early people involved in that. I've edited the JBJS. I've edited the BJJ. I've founded and edited that, BJ360. I've founded and edited the Journal of Hip Preservation Surgery. I have my own Amazon page. I've written for the newspapers of the UK, and I have my own travel blog. I am a trained journalist, which means you can not believe a single word that I say, but I'm going to try and persuade you differently. You see, times are changing. Look at publishing overall. Our reading habits are changing. Costs are changing. We are in a something for nothing world, and we are becoming increasingly specialized. Look at the USA daily newspaper circulations and how they are now declining. Look at how the number of minutes we spend reading articles are declining. Look at the advertising revenue and how it is declining. And look at how actually digital advertising is increasing. The world is very different now to how it used to be. And everything you see in the non-academic publishing world, believe you me, applies to the academic publishing world. There is delinearization. Sadly, I am of the generation that used to receive the JBJS, and that used to be what I would read every month, and I felt my education was complete. But no longer is that true. These days, we are like little lambs in the field. We get a bit of information from there, a bit of grass from over there, a seed from over there, and we build up our own picture. We are now delinearized. How much do we read? Believe it or not, we read 270 articles a year each. Now, by read, I don't mean read from beginning to end. We open, we peruse, and we take the information we require. Our reading time has declined. So we used to spend up to 50 minutes reading an article. Now it's 30 minutes or even less. Meanwhile, when it comes to writing a paper, you are going to spend 100 hours on your backside. Okay, that is a long time to write a paper. And so you've got to get it right. Let's have a quick look at countries, because certainly as an editor, certainly in understanding the scientific literature, the USA and China are key. They publish more than any of us put together. I put Greece, you're down there, we're down there. Okay, we've got a lot more work to do, but look at China, look at the USA. And if you're intending to found a journal, a new journal, you've got to keep those two countries in mind. Without them, you are going to fail. Then there's open access. By that, I mean that we as readers do not have to pay. We can go online anywhere in the world. We can get the information we need. Now, as scientists, and I'm simply looking at neuroscientists here, the open access is increasing enormously. The pandemic has almost doubled it beyond the figures I show you there. And open access is good because it's much cheaper, okay? But the margins are much smaller as well. Of interest, if you have a standard subscription journal, which is both print and online, you're going to spend nearly $5,000 on a single paper in your journal, okay? You can make out less than half if you publish the same paper by means of open access. So you can see why many people are going open access these days. Associated with that, of course, is the APC, the article processing charge. We as writers, as authors, are obliged to basically pay some money to a publisher. And that sort of gives it a slightly down market feel in our mind. We feel we've purchased publication. We haven't. Okay, it's something you have to get your head around. The APC, however, is open to abuse and to criminality. Research fraud. Now, that's a whole lecture, and I won't bore you with it now, but authors are fraudulent, editors are fraudulent, publishers are fraudulent. Let me give you an example, because we can get wound up and caught up in research fraud without even realizing it. I now am the science editor for the World Health Organization. Somebody rang me up last week and they said, can we please put this surgeon on this paper because we need to increase our presence in the Yemen, which was the country we were talking about. Now, what do I say? That surgeon had absolutely no idea that the paper existed. He had absolutely no, he'd played no part in it at all. Do I say yes or do I say no? Do not raise your hand. I said no. Do not raise your hand when I ask this question, but how many of us have been asked by our juniors, can I put your name on the paper? How many of us have been written to by colleagues around the world and said, let us put your name on the paper because it'll increase our chances of being accepted? It won't, but they feel it will. All of that is research fraud. Try not to get caught up in it. Anyway, you want to be published, you dream up a project, you write a paper, you submit it to a journal, it undergoes peer review, you wait and you wait and you wait. And eventually a decision is reached. And that decision is it is either accepted or resubmitted, likely resubmitted, or it is rejected. You're trying to avoid, of course, ending up in the Journal of Universal Rejection. This actually exists. It is based on the fact, of course, that the very eminent journals have a very low acceptance rate. The lower the acceptance rate you have, the more eminent your journal. So why not have a journal which rejects everything? Because then it is going to be the most eminent journal. So that was why the Journal of Universal Rejection was invented. It is, of course, a joke, but it does actually exist. Anyway, you resubmit your paper, you submit it back to the journal, and as a rough guide, there will be an acceptance rate of 20%, is the sort of rate you would expect. You are probably feeling hard done by that. It's the journalist speaking now, out in the big wide world of writing, okay? You have a manuscript. You send it to an agent and you hope that agent will find a publisher. If you haven't done it, try it because it puts life in perspective. An agent will receive 3,500 requests every year. They will only select 3 or 4 authors to represent in a year. So many people try and bypass the agent. A publisher will receive 5,000 manuscripts every year. 95% of those will be rejected. 5% will have a second look. Their publication rate, their success rate is 0.25%. So if you feel hard done by, think again. If your manuscript can't find a home, however, we say as writers, then the best place to look for the problem is in a mirror. I mean, do you ever feel lonely, abandoned, unloved, and ignored? Because if you do, I mean, think of Edward Jenner, the smallpox vaccination, rejected, okay? Think of Harry Potter, 12 rejections until the daughter of the publisher picked it up and said, "Daddy, let's have a go." And I love this one, Albert Einstein, who writes to the editor as follows: "We had sent you our manuscript for publication and had not authorized you to show it to specialists before it is printed. I see no reason to address the comments of your anonymous expert. On the basis of this incident, I prefer to publish the paper elsewhere." Wouldn't we all love to write such a letter? Then which journal? What would I look for? Well, I want to look for a highly visible journal read by my peers. I want it reviewed by specialists in my area of interest. I want a fast turnaround, please. I want a reasonable acceptance rate. I want it to be indexed in databases so the world can see it. I want a regularity of publication. It doesn't have to be every month or every week. It can be every quarter if you like, but I want the journal to appear on a regular basis. I want to think about the expenses involved, particularly with open access. It may cost me $3,000 or more to get a paper published, assuming it is accepted. And I am certainly thinking open access because I want the individual who lives with no means at all in a war zone in the world to read my paper just as easily as somebody who works in a teaching hospital in a major capital city. Reviewers, I'll mention very briefly because Michael's going to give a far better presentation than me on this. But there are 2 types of reviewer. There's the perfect reviewer, which we all seek, and there is the reality. Just tell me what you think when somebody writes a letter to you or an email to you and asks you to review a paper. Are you very happy? Do you skip around? Or do you think, oh, good heavens, I've got extra work to do? I won't embarrass you by asking you why you've chosen the second option. But the feature is that every paper has a message. It doesn't matter how badly it's written, it does have a message, and decisions are frequently a compromise. Now, can you influence a reviewer? Remember, reviewers don't particularly want to review. Okay, that's the starting point. Secondly, they are humans. They are human beings. You've got to work on that. It's like fly fishing, okay? You don't just give them a paper and say it's full of all the information. You construct it in a very methodical way. You land the fly on the water and you bring the reviewer to you bit by bit, and they don't know you are doing it. Okay, you look at quality of writing, quality of presentation, and the content very well, but let's look at the shape of the paper. Now, I can't cover everything in this short time, but how about the title? Let's start with something simple like a title. Here is a title: a randomized controlled trial of 478 bingo total hip arthroplasties. I invented the name. 5-year medium-term failure. Now that is a typical title. I imagine you can't see anything wrong with it, but let me just change it. Early failure of the bingo total hip arthroplasty, a randomized controlled trial. Now, suddenly you have exactly the same title. You've given it a little bit more active sense. It's a little bit more exciting. The reviewer, who basically has forgotten to iron his shirt, is late for work, the butter has gone off in the fridge, and he doesn't really want to read your paper. He suddenly looks at this title and he says, I want to stop. I want to read this. I'm going to ring up the clinic and I'm going to tell them I'm going to be late. The abstract, do not leave the abstract to the most junior person in the team. You're going to have to live with this. This is what people read on PubMed. This is what people are going to cite forever and a day. It is quite likely your reviewer, even though as editors we would wish differently, it's quite likely your reviewer will judge your paper on the abstract. The introduction, your children at home. They're about to go to bed. You want to relax them, okay? You sit them on your lap, all right? You say, once upon a time. You gently coax them. Okay, you're doing that with your introduction. You are telling a story. You're not trying to win a Nobel Prize. You are trying to persuade a reviewer to say, yes, Okay, we do that all the time as writers. We call it pitching. So you do basically a nice, gentle introduction, and instantly they're looking at it. When you go into a bookshop and you open a paperback and you are wanting to buy the book, how do you judge it? You read the beginning, you read sometimes the end. You read those two things. You look at the blurb on the back and you make your decision. The blurb is the abstract. And believe you me, people will often look at the introduction and they will also look at the end. Have a conclusion that matches your introduction. The central portion is clearly important, but the reviewers may give that a miss. And finish where you start. If you introduce a concept, then basically you finish with it. And when it comes to references, I, as an editor, I look at whether anybody's referred to my journal. I put that to you, okay? I'm not saying it's essential. I also look at the dates of the references. So if you're publishing in 2022, you don't have your most updated references 1998. Then stick it in the bottom drawer, leave it there for at least a week and go back and read it. And I promise you, you will think it's the worst thing you've ever written and you will rewrite it, and it is right that you should. The dilemma, well, we have dilemmas. I'll be very quick. Here's one paper. We've got 4 reviewers. The first guy said, accept it. The second guy says, accept. Once we've done a revision, however, which he was asked to do, then the second guy said revise. So he changed from accept to revise, and he then changed from revise to reject. Reviewer C, revise to accept, accept to revise, reviewer D, revise to revise, revise to reject. How do you make sense of that as an editor? You can't. So it is a subjective decision that you have to take. So in my perfect world, what do I wish to publish? I want an original idea that no one else has seen. I want it well written and well presented. I want authors happy to amend. I want the authors happy to adhere to a deadline. I want it scientifically sound within reason. Okay, you may have brought up some subject which nobody's come on before, so we can be a little bit scientifically lax in such a circumstance. And I like it to be cited widely. That, gentlemen, ladies, is my idea of the art of publishing a paper. A lot of it is psychology and plenty of it is fact. Thanks indeed.
Thank you, Mr. Viller. This was outstanding, and I've been at numerous presentations on paper writing, but this is enthusiastic. It let us grab to a pen and start writing. And I understand you have experience both in the normal world, but also in the academic world, how to read and write papers. Any questions from the room after this excellent presentation? I love the English, by the way. The question is, shall we publish in more open journals, or shall we stick with the papers journal that we all know? And shall they move on to be only digital, or shall we get them through the mail?
Sure, the pandemic has made a big difference to all of this. As of about 2016, I think, it was possible to find more than 50% of all scientific information free on the internet, and that number has increased enormously. Northern Europe, UK, at the moment seem to be leading the way for open access for reasons I don't really understand. People are often saying to me, which journal should I choose? Or they have in their mind, I want it to appear in a specific journal, because they believe life is as it was 20 years ago when people are just reading this one journal. But if we look at our own behavior and we want to find something, then you're probably on your mobile telephone, you're probably on Google Scholar or PubMed, and the last thing you're thinking about is really what the journal is. So as an editor, the key issue for me is to get my journal indexed. So I believe we should be being as open as possible. I believe information should be free. I simply do not see why somebody who has no money in their life at all should not be able to access the work that the likes of ourselves publish. I think everyone should do it. Free information is critical.
Thank you very much indeed. Yes, there's a question. Please move to the microphone and state your name and where you come from.
Chris Palliber's Hereford.
Thanks very much for the introduction and for a fantastic presentation, Mr. Villa. May I ask you the question you asked earlier? So could you give us 2 or 3 pearls of wisdom about how do you get your registrar to make that happen?
It's a difficult one because Daniel was 1000% correct, is that you've got to answer a suitable research question. But as you know, because we work together, I keep data. I record everything. If a patient passes wind, I put it in the database because I don't know if one day there may be something that I haven't thought of today, but which will be relevant tomorrow. The important thing is you need the data. A registrar, a trainee will be with you for 6 months or a year. Okay, it's going to take him that 100 hours of work to do. And the paper is bound to be rejected or revised first time round. So you're looking at about a year, 18 months of work, aren't you? You've just got to follow it through. You can't do anything else. And the only way of doing it in my world is to have the data they can use, and you're inventing questions all the time. But the trouble is that the short training programs don't lend themselves nicely to the in-depth paper. For example, we're setting up with WHO at the moment, we're setting up a link with Cambridge University, all right, dealing with the injuries of conflict in the occupied territories in the Middle East. Now, all that really interests Cambridge is getting published. All that really interests WHO is having the information. We can't get a professional junior, and I think quite rightly, to work with us until such time as they're pretty sure they can be published. You know, you don't want to start a 6-month job and then find you haven't got evidence of having done it at the end, and that evidence is going to be on your CV, isn't it, as a publication? So I haven't answered your question, Chris, other than to say you've just got to keep your finger on the pulse and you've got to directly assess them. And quite often also remember your juniors may not come from an English-speaking country primarily. And so you've got to be sure it's constructed, the paper, in a credible way.
Renee, can you hear me?
Yes, yes, please. Go ahead, Daniel.
Yeah, I have a question for Dr. Viller.
Make it easy.
Well, as editor of an open access journal, I'm always concerned about these predatory journals that exist. Can you give some tips for people to how to identify those predatory journals versus more reputable online access journals?
There's a whole. There used to be. There was an ex-pharmacist, I think, wasn't it, called Beall, B-E-A-L-L. There was a thing called Beall's List, and Beall made a long list of the predatory journals. And so when you got an email from the Journal of Gobbledygook Research, and in my case, they normally say things like, "Dear Dr. Richard Ricky R.N. Villa, Dr. Mr. Due to your," and it's written in very bad English, but they're getting better, aren't they, Daniel? And so you just need a threshold of suspicion. What is more, some of the journals are now being hijacked. So you take a website and you've been looking at it for a long period of time, and that website is hijacked. I've got evidence of that, particularly in the environmental world, and you are submitting your paper, you think, to your journal, but actually the money is being paid to a completely different journal. So it's basically, it's warfare out there. A lot of the time you can pick it up. People tend to stick, I think, with the familiar ones which they trust. But then you have this paper, of course, that you cannot publish because people keep on saying no, and then you start putting your toe in the water. So it's a risk. It's an awful risk. Generally, we think we can pick it up, but I think even I get caught out from time to time. Now, Daniel, what have I said that I shouldn't say, or what should I say that I did, if you know what I mean?
Well, again, I think you know, when you get an email and you're considering one of these journals when you're having trouble getting a paper published, look at that journal online and look at the quality of the work that is or isn't there. And again, I think sticking with reputable journals that are indexed in PubMed or Google Scholar, those tend to be more reputable journals. And the other thing to look at is the publishing fee, because the publishing fee tend to be much, much higher in those predatory journals.
Yeah, no, that's wise advice. And Daniel's absolutely right. It is predatory publication is a big issue, increasingly so.
Okay, thank you very much, Dr. Viller. This was outstanding, and I love the discussion. And yes, please. I'm sorry. Apologies.
I'm getting good exercise here.
Thank you, Richard. I enjoyed very much your talk. Absolutely superb. Let's say that you did 100 labor repairs, hip labor repairs, and with 20 years follow-up. How do you judge which journal to submit your paper? What is your feeling with that?
Yeah.
Is it biased, or
No,
you have to answer me a true answer?
I'm so old that I can be as biased as I wish, because people either think I'm wise or demented. So that's absolutely fine. No, look, the important thing with a paper is to be honest. All right, people try and cover things up when they submit to journals, and we're pretty wise as editors to the tricks and when things are covered up. If you've got 200 labor repairs, you follow them up for 10 years, and it's a retrospective study, you're not comparing them against anything at all. This time, 20 years ago, the only option you had, of course, was the more general orthopedic literature. You might have had the arthroscopic literature, but you were in an era when the endoscopic hip surgery was fairly new and untrusted, and it had a very high rejection rate. These days, you have more specialist journals. Now, as you'd expect, with a title like you've given, I'm an utter enthusiast for the Journal of Hip Preservation Surgery. It was created for the very reason that there was a hugely high rejection rate of papers that, as hip preservation surgeons, we felt ought to be published. And we felt that was because, firstly, that all editors have got a limited number of pages they can fill. You've got a little bit more flexibility with open access than you have with hard copy, but at the end of the day, you can only accept a certain number of papers. So if you're not high profile, or you're not in their mind, it's harder to get through when that decision is made. Very few papers, my colleagues, Michael may correct me, but it's very few get accepted first time round. It's almost worthwhile. And so there are various points as an editor, then you've got to make a decision. Do I revise this? Do I get this paper to be revised, or do I not, for example? The very, very few are accepted first time round. And sometimes papers come in that you feel should be accepted, but your authors haven't, but your reviewers have said no. And so you have a dilemma. There's a lot of people handling that goes on with being an EIC. So to cut it short, your particular suggestion, I would be personally thinking I'd either be, I must say JHPS, because that's what I do. But there are other journals too.
Thank you. Thank you again. And shall we move on to presentation of Dr. Rossi on the manuscript reviewing, which is something that many of us do as well. So thank you for joining us here.
Good morning. Can you hear me?
Perfect, perfect. Thank you very much.
Great. Well, good morning from the state of Washington. Absolutely fascinating talk by Dr. Villar, and I think I can, I hope to follow the last two speakers. I would like to thank Dr. Iosophides and the Greek Arthroscopy Association for your invite, and kind regards to Dr. Gergolis. My talk today is to speak about the pearls for successful scientific paper review, which should supplement what was just talked about in the last two speakers. This can also apply to reviewers. in addition to authors and editors. I do not have any disclosures. I am a member of Arthroscopy Association of North America. I am the assistant editor for arthroscopy. And I also need to disclose that I may be the farthest located presenter at this conference in the Pacific Northwest of the United States, perhaps outdistancing myself from my colleague, Dr. Washer in New Mexico. So thank you for having me. I represent Arthroscopy, which is really a trifecta or a family of journals. The Arthroscopy Journal is the heart. Arthroscopy Techniques is our peer-reviewed video journal. And then our most recent Arthroscopy Sports Medicine and Rehabilitation is our sister, fully open access sister journal. So these perspectives that I'm presenting today are from that triad of journals. Today, I'd like to talk about successful pearls to review a manuscript, the organization of the manuscript, its common pitfalls and critical parts, tools to improve the manuscript, and how to become a top reviewer. To do this, I will really go through the manuscript just as Dr. Washer did for the organization of a manuscript, the title, the abstract, introduction, methods, results, discussion, conclusion, references, tables, and figures. And we'll go in that outline to talk about what the specific pearls and controversies can be. First, the introduction must be brief. It should identify a very specific controversy, as Dr. Washer stated. It should state the purpose. It should state a very specific hypothesis and really nothing else. Let's give an example for the introduction. A controversy can be, does double row rotator cuff repair improve outcome? A purpose may be to compare outcome after double row repair versus single row repair. And the hypothesis should be what the authors think the answer will be before the study is started. And that can be in the form of a null hypothesis. Moving on to the methods is absolutely critical. The method should include the time frame of the study, very specific inclusion and exclusion criteria. The methodology should be a step-by-step description, which is reproducible, just like a cookbook, so other authors can reproduce this. For basic science studies, the rationale for the experimental design should be given. This should be followed by the statistical methods, and all the methods in the should be reflected in the results and vice versa in identical fashion in parallel. Methods are the most important part. Fatal flaws in the methods cannot be fixed. And the authors really should get advice on the methods before the study is started. For prospective studies, that means before the study is started. For retrospective studies, of course, that means before the data is extracted. We have to examine the level of evidence. There are different types of studies. The clinical studies are the most common. Therapeutic studies tend to be our most profound studies, but there are also diagnostic, prognostic, and economic studies. Our level 1 through 5 studies have to be chosen. The level 1 studies are randomized control trials. They are our best studies, but of course they are our fewest studies. Our comparative studies are our level 2 and level 3 studies, whether they are prospective or retrospective respectively. Our case studies, which have no control group, are our level 4 studies. And of course, our level 5 studies are our expert opinions. There are some studies that do not have a level of evidence, and these are our biomechanical studies, our cadaver studies, and our basic science studies. When we examine the methodology, it is important to examine for bias. Bias can be the most important part of the assessment. First, selection or allocation bias. That means that the treatment groups have different prognoses. Are you comparing apples versus oranges? Meniscus repair plus an ACL in a younger population simply cannot be compared to meniscectomy without an ACL in an older group. They just can't be compared. In order to prevent selection bias, we have techniques: randomization, blinding, strict adherence to the inclusion and exclusion criteria, and matched groups. Detection or recording bias occurs with outcome recording methods that differ between groups. We prevent that by standardizing the process, completing forms in private. Operating surgeons should not perform the assessment. To prevent the reporting bias, we use appropriate and validated outcome measures. Can we use universal, which allows comparison to similar studies, such as PROMISE? Should we use condition-specific or general health measures, surgeon-reported or patient-reported? These all should be decided beforehand, but should be able to be compared to appropriate literature. Transfer or exclusion bias. Patients which are lost to follow-up. Are we selecting out patients that did poorly? Our goal, of course, is an 80% follow-up at 2 years. That's our gold standard, and we try to adhere to that. Performance bias has to do with the heterogeneity in our comparison groups. Who performs the procedure? There's really no right answer to this, but it is really important to consider and divulge. Statistical significance, critically important, p-value less than 0.5, but it is only a guide. Statistical significance cannot address clinical relevance, and it is frequently fragile. What does that mean? Well, different outcomes in a few patients, if the patient numbers are low, can remarkably change the results. More importantly, clinical significance is vastly more critical. We need to consider MCID, minimally clinically important difference, which is the floor or the smallest change detected by patients. The PASS, the patient acceptable symptomatic state, is the feeling of being satisfied. Another benchmark, which is slightly higher, is SCB, significant clinical benefit, or the ceiling of feeling substantially better. Then there are other parameters such as maximal outcome improvement, which are ratio based on their preoperative status. But most importantly, these thresholds need to be, the authors need to remember that these thresholds are patient level metrics. They are not group level metrics. What does that mean? Well, that means that you need to use the percentage of patients reaching these thresholds such as MCID, PASS, and SCB, not the average of the group. And that is a common mistake that we see that needs to be caught. Confidence interval are vastly more informative than p-value. 95% confidence intervals give a degree of certainty, and the confidence intervals tend not to overlap. If you have overlapping confidence intervals, this may indicate a lack of clinical significance. Of course, multiple statistical testing. Of course, if researchers use 20 different outcome measures, they will eventually get lucky, and that's a p of 0.05, and the results may not be reproducible. Of course, the solution is to choose a primary outcome measure for your hypothesis that has been tested for a preoperative or a pre-study a priori power analysis. Be very careful of results that show no difference. This is a red flag. The power analysis should be checked. Why? Because they may be subject to beta or type 2 error. Be alert for this, for no difference between groups. They may have too few patients, too small a sample size, not enough statistical power. The results could be wrong. The results should be organized in parallel with the methods. Everything in the method should be reported and vice versa, presented clearly in tables and figures so it's easier to read, and then accurately cite them. Tables should be concise, group them logically, label the columns clearly, and they must contain the number of patients, the mean, and the confidence intervals. This is important because more and more we're presenting these in our social media. A picture is worth 1,000 words in figures. Labels and arrows are critical, and especially in arthroscopic surgery, we have to include the side, the patient and the viewing position, the viewing portal or the imaging view, appropriate labels and arrows, and a detailed description. Moving on to this discussion, we really need to compare and contrast to similar publications. We state the main findings, and then we try to explain the differences that we found from previous studies. Try to address the controversy that we established in the introduction. We wrap up the discussion with the limitations, point out the weaknesses before the conclusion, and consider the biases that we spoke about before. The conclusion should state if the hypothesis is supported, but the most common failure that we see is they are not specific. They are not reporting the results, and they should not be extrapolated. Moving on to the beginning of a paper, the title is critically important. The goals of all journal article titles should inform the readers, but they should also attract attention. Attributes of a successful journal article title include it must be accurate. It should be short without sacrificing keywords. It should describe conclusions of the study, generalizing the study's findings. The title should avoid misleading statements or representations. It should avoid hyphens, proper nouns, and locations. And we really should try to get away from new or novel and let the readers decide. A quick talk about systematic reviews and meta-analyses. Systematic reviews should have strict adherence to inclusion and exclusion criteria to minimize bias. Because these type of systematic reviews are qualitative synthesis of data, they have low level of evidence, high risk of bias, heterogeneous study, and because of that, they should avoid improper pooling and summary estimates in the plots. Meta-analysis, on the other hand, are generally quantitative synthesis. They should be limited to randomized controlled trials. They have low heterogeneity as determined by the I-squared analysis, low risk of bias, and high level of evidence. Let's move quickly on to tools to improve scientific research. We published in 2018 our tools to improve scientific research, which included review templates and checklists specifically for original articles and systematic reviews and meta-analyses. These are presented and look as follows. And you can find these on our website under reviewers and under original article and checklists and templates. In addition, we have tools to improve scientific research. We have a list of research pearls. This is a list of 24 articles to talk about level of evidence, biomechanics research, titles impacting citation rates, reporting outcomes, clinical significant difference, Delphi, methodology, statistics, and big data, among other topics. To become a top reviewer, we recommend confidential comments to the authors, but also line-by-line feedback to the authors to make this a better paper. Reviewers are not copy editors, but copy editors are not surgeons and scientists. So copy editors correct spelling and grammar, but reviewers such as yourself can be correct confusing science. I encourage everybody to sign up to be a reviewer. You will greatly enjoy it and learn from it. We have an option at Arthroscopy Journal. We'd be happy to have anybody who is interested join us on our social media. Again, I wanted to go over our organization of the manuscript, its critical parts, common pitfalls, tools to improve the manuscript, and how to become a top reviewer. Thank you very much for having me, and if there's any questions, I'm more than happy to entertain them.
Thank you, Michael, for this nice presentation and explanation how you can get a reviewer and editor. Nice seeing you again. I remember your perfect reviewers earlier before you got an assistant editor-in-chief of the journal. A question: can you sometimes there is the editor is wants to decide, and it is between accept and or reject. Sometimes the question of the paper can be interesting for the journal, and that can be a factor to help the writer to give it back, and so to give him an opportunity to accept this paper because of the interest of the journal. Can you say to us, and perhaps for some young people, some ideas or some questions that are now very interesting for the arthroscopy journal, for example?
Absolutely, and thank you for the question. It's an excellent question, and it does have to. It does pertain to the topic. So if we feel that a topic has high impact or high relevance in the literature today, that certainly has a bearing. And if there are some systematic problems with the publication that can be addressed with an ample review, then we tend to lean towards revise rather than reject, because the impact of an article, of course, is our ultimate goal. What do our readers want? And so certainly we can work with some minor flaws of a paper to try to correct them. If, of course, there's a major flaw that is impeding the actual conclusions or changing the conclusions, that changes things. But if we feel that the paper has a high interest or a high impact that will change clinical practice or will change future research, that goes a long way, and we will err on the side of revising for sure.
Any question? No. Richard.
Michael, Ricky Villa, brilliant presentation, fantastic. I'd be interested to know, when you get a review back from the reviewer, how much emphasis do you place on the decision of the reviewer, whether it's accept, revise, or reject? And how much emphasis do you place on the logic the reviewer has reached to reach that conclusion? Because reviewers say different things about the same paper, don't they?
Yes, Dr. Villar, thank you. That's a very impeccable question. You've hit the nail on the head. So the answer is probably very little on their decision, on their overall decision. It's the reasoning behind their decision. So if they're explicating the paper like I just outlined, and they give an outline of a very significant bias that may not be repairable, and they say revise, well, if it's a fatal flaw, we may have to change that decision. If, on the other hand, they say reject, and there really isn't a fatal flaw and it has a high impact, and they've given an excellent explication of the article that can be addressed with regards to the errors, then we may change it the alternate way. So really depends on the quality of the review, not the final one decision. We also have our reviewers rank it in different categories, and that can, sway us in one way or the other. So that's exactly right. I think it depends on their overall explanation and reasoning and their logic rather than their final decision.
Thanks. Yeah, I'd agree with you 100%.
So no other questions. I am most grateful to the speakers for this outstanding presentations, lively, discussing, full, and I'm sure that the younger ones will spread the word that for their future, paper writing is indispensable in their career. So thank you very much to the speakers and to the audience. And we'll have.
Thank you.
Thank you, everybody.
At DePuy Synthes, we are driven by one purpose: to keep people moving. How do we do it? By putting innovation in motion. Innovation like the Dynacord suture, the only high-strength suture that self-tensions when needed to maintain a set approximation force. And we put innovation in motion with View Tower, featuring the PureView 4K visualization system that delivers excellent real-time 4K image quality, as well as comprehensive case and image management controllable by an intuitive user interface or remotely via a mobile app. Innovation in motion continues with our fast-growing TrueSpan meniscal repair system, a meniscal implant designed to be simple, robust, reliable, and low profile. Soon, we'll be putting innovation in motion with a range of new educational workshops designed to help surgeons get up to speed quickly with all the latest advancements. Every innovation has helped us set a new standard of care for stakeholders across the care continuum.
ConMed blades and burrs are designed to help provide performance, versatility, and dependability. ConMed's Crystal View Pro Fluid Management System is a simple, intuitive, and reliable inflow-outflow system that provides a crystal clear field and optimal joint distension during arthroscopic procedures. From small tears to complex repairs, you can perform faster meniscal procedures with less meniscal trauma with the Sequent Meniscal Repair Device from ConMed. For a lateral row rotator cuff repair, the All-Peak Pop-Lock Knotless Suture Anchor from ConMed provides reliable subcortical fixation. ConMed's Why Not family of all suture anchors offer a small size, strong fixation, and a simple technique. ConMed's Paradigm Hip System is a complete portfolio of products designed to provide surgeons with simple, safe, and reproducible solutions for arthroscopic hip procedures. ConMed, imagine what we could do together.